the our entire studio go down here. I'm working virtually from the I-45 now virtual studio up in Nassau Bay. So my apologies for that. But now we are on the air. Hopefully, I will check with our private in there. David, you seeing me good there? I'm checking with our producer back at UTMB Health, and if he can give me the thumbs up there in our private chat area, we'll be knowing we're going. We got a good show for you here today. We're going to be talking about cardiac health, and by the way, some exciting news coming out of UTMB Health's Clear Lake campus. And bringing in right now our guests here. They are Mary Phillip, who is the Associate Chief Nursing Officer for UTMB Health Clear Lake, as well as at the League City campus, and then Dr. Elizabeth Davis, a fellow in cardiology for UTMB Health. Ladies, sorry about that. What it is, we were talking for 30 minutes, everything was just fine, and then everything, just as we ready to go on the air, we have the problems come up. But both of you, thanks for coming on. We appreciate that, and it's an exciting news coming out of UTMB Health, and particularly in Clear Lake, the reaccreditation of that as far as for cardiac care, particularly in cardiac pain. So, Dr. Davis, can you tell us what that's about? And also, Mary, join in with her here about what exactly does that mean for folks so they can understand? Because we see accreditations all the time, but what does it really mean for the patient?
So, for us as practicing cardiologists, we have several different governing societies that tell us what is considered good care. What is the standard of care for doing something like approaching heart attacks or chest pain or other cardiac issues? One of the more important ones is the American College of Cardiology. And that's the one who this particular type of accreditation came from. And basically what it comes down to is they've set a standard for how we should be approaching chest pain in our patients. They look at things like patient satisfaction, but also patient outcomes. They look at medications, readmission rates, days to discharge, and safety measures. And so for a hospital to be accredited as a chest pain center, it means that they have met all these guidelines that have been set by our governing societies. It is a process that we've enrolled in order to be able to say that, yes, we are delivering the top level care as expected by our governing societies. It's not something people have to do. Hospitals have to do this. It's something that we have chosen to do to ensure that we're delivering the best care possible.
And Mary, that I would take it then it's that badge of accreditation there means that if someone sees that is that symbol to say, hey, almost like the good housekeeping seal, like hey, if you're feeling pain when you come in here in your chest, you're at the right place. Is that right, Mary?
Yes, absolutely. And really, the chest pain accreditation, like Dr. Adams was saying, is that it really just sets a standard. Like, this is what we really should be doing for every patient that walks into the hospital. And what's really great about this program, and really what it makes us elevate our level of care, because it actually starts even before the patient even gets to the hospital. So we really work with our local EMS partners and our community members to really, one, let patients know exactly what signs and symptoms they should be looking for. And then the indicators, quality indicators that's a part of this accreditation process continues into the facility. So from when we're notified that a patient is having a situation to when they get into the hospital, there are certain quality indicators and time measurements that we actually have to meet to really be able to obtain this certification. So when a patient sees that certification within our community and within our hospital, they know they're receiving the highest level of care for cardiac care.
Mm-hmm.
And that's important because one thing is, and a matter of fact, and one of the reasons, matter of fact, we were supposed to be doing this show a few weeks ago, and during Heart Health Month, and in February, and I had my own issues, and so I've been seeing my cardiac team for a while. And one of the things that Dr. Hani Janid has always told me is that when we work on this, we actually do a lot of process of elimination, because symptoms can be, you can say, I've got chest pain, but that doesn't allow you to know right off the bat as a doctor what you're supposed to do. Correct, Dr. Davis?
Correct. I think a lot of people equate chest pain with heart, but there's a lot of things that live in the chest besides the heart. The heart is there, part of the esophagus, the top part of the stomach, also the lungs. And all of these things can present with chest pain. Even within the heart, like even heart pain is not always a heart attack. There are other things that can be going on with the heart. You can have inflammation of the heart called pericarditis. You can have valve diseases that can present as chest pain. So someone coming in with chest pain is definitely not a slam dunk diagnosis, and it is a process of elimination.
And you're seeing, by the way, too, the press release from the UTMB Health website that referring to that accreditation coming in. But and also too, when folks, you put it out best there, Dr. Davis, is that when folks come in, they have that. It could be anything when you have that chest pain. But what are the kind of signs, or what are the kind of the warnings for folks if it's a cardiac issue?
So some of the first things that we look for are the characteristics of the pain. Classically, meaning in most patients, heart attack chest pain is a heavy, sitting, elephant crushing, that's the stereotypical description, pain in the center of the chest. It can radiate to the left arm and the neck. So when people especially come in saying that I have chest pain in the arm, that's one of those red flags for us. We also look for associated symptoms. Do you also have shortness of breath? Does it feel like the heart is racing? Are you sweating? These are also very typical of cardiac chest pain. Having said that, it's important to note that not everybody presents the same way. Women, elderly, and diabetics often have what we call atypical presentations of chest pain. They might feel more like an indigestion kind of pain, a stomach fullness. They might notice more of a weakness, fatigue, rather than like actual shortness of breath. It's also important to note that while a lot of times like chest pain from a heart is a sudden onset, and for some people, it starts out kind of slow and gets worse. So while we do have our red flag symptoms that we look for, there are other things that should get your attention too. So if you're having chest pain, whether it is that sudden onset crushing elephant pain with shortness of breath, or if it's more of you don't feel well, you don't feel right, and you're kind of having this discomfort, but not real pain, that could still be a heart attack, and you absolutely should see a doctor very soon.
And Mary, you see the doctor, but when it comes to coming into the Clear Lake campus, particularly, the first person they're probably going to see is a nurse.
Yes.
And that's where the triage starts. And talk about your staff of how, particularly in that cardiac area, what are they looking for? What are the questions they're going to be asking to make sure that best care is being taken care of?
Yeah, so what they're going to ask for, they're going to look at risk factors, they're going to look at the age of the patient, what they're coming in, and just like what Dr. Davis was saying in regards to the symptoms they may be having. And, besides just the chest pain, the feeling of like you're going to throw up, the nauseousness that may come with it, sometimes you may have pain in your stomach, kind of to what Dr. Davis was saying, some of that abdominal issues that you may be having. And as soon as they identify that, what you're going to see is you're going to see them do a couple of things very quickly. One of the biggest things that they're going to do is do an EKG, and that's really where they monitor your heart rate. And they really want to get that done within 10 minutes of when you're walking in. So you walk in, you tell them you're having these symptoms, and don't be surprised if all of a sudden you have a couple of people on top of you and you're getting monitors placed on you as quickly as possible, along with some blood being drawn. And one of the accreditation guidelines is really trying to get that done within 10 minutes. And so again, that goes back to the importance of these guidelines to kind of give us these best care. So do see that. And so you may see one or two or three people all of a a sudden coming at you as a patient coming into our ER, and you'll be getting your blood drawn, you'll be seeing a physician very quickly, and you'll be getting an EKG, which is that monitoring of your heart rate. And really what they're looking for is for different rhythms that they may see that's sitting there showing our providers, hey, you're having an actual heart attack.
And it really, and you brought out all these people are coming at you. It's a team effort. There's not just one or two people taking care of you at any given time. It's that team effort. In fact, that's what I thought we'd, well, let's see here if we can bring it up a little bit better. Well, I thought we'd have it here, but we're having trouble getting our images to pop up here. We had photos of the team. Come on now. We're having all sorts of, sorry, folks. We had this up and it was working so wonderfully when we were up there earlier. Let's try it one more time. Yeah, it's just not going to work for us here today. We'll bring it back in here. But I wanted to talk about it because there's a couple photos we have of y'all's team over there. When it comes to in this reaccreditation, as I understand it too, one, the actual accreditation came during the middle of COVID. Yeah. So not a whole lot to, it's like not even high fivings when you do that. As everybody had from 6 feet away had to do that. But that's one thing. But to be able to then get the reaccreditation, that means, hey, you're not resting on your laurels. You've actually upped your game in many ways because the baselines, while they're there, I'm sure that, you got to get that better response from there. Talk about the effort that goes into that reaccreditation work.
Yeah. So, again, it's a team effort. We actually have a cardiology program manager. Her name is Clarissa. She does a wonderful job and she's really the lead, and she works with, our providers and our cardiologists. And so we have, one of our cardiologists is a general cardiologist. So he's able to come in and see patients. He's the one that really sees a lot of our chest pain patients, along with, Dr. Davis and the fellows. They'll come in and see those patients. And then we have our other group of our interventionalists. And they're the ones that you're going to see in the cath lab. If you have a patient who's having a heart attack, they're the ones that are in the cath lab very quickly and trying to get your valves open, right? So when you're having a heart attack, really your arteries they're clogged up with something. And the most important thing is to open up that blood flow. And so you'll have that interventional cardiologist that'll be another person on the team that's really working through that. And so when you're going through these accreditation processes, you're not just looking at them coming into the hospital, but you're also looking at, how fast does it move from you get the EKG, how fast do you get them into the cath lab? And then even after the cath lab, now what's the care of the patient? So it's even post procedure, right? And so they're looking at all those guidelines. And so the accreditation component of that, it's not just looking at the very initial thing, but it's also following the patient through their entire care, and not just in the facilities, but even when they go home, do they have appropriate outpatient care that they can receive? And that's all a team effort. That includes the ER, the inpatient, our cardiologist, our ICU doctors, because they'll end up in the ICU if they have a true heart attack. And then even our cardiologists on the outpatient basis. And so they go through the entire spectrum of care, and that really does take a team effort.
Yeah. Mm-hmm. And Dr. Davis, when you talk about that team, at some point you come in the room on that. Yeah. And when you come in, you've got to get that feedback from that team. That's super important, is it not?
Oh, it's incredibly important. If you don't have a well-functioning team or a team that's not communicating well, you're not going to be able to provide the high level of care that we've come to expect of ourselves. And so we have constant lines of communication between us, the ER doctors, the intensivist, even amongst cardiologists. As Mary mentioned, there's multiple types of cardiologists. And so when someone comes in with a big heart attack, usually the first one you're going to encounter is a general cardiologist, which is what I'm currently training to be. That means someone has completed medical school, 3 years of residency, plus another 3 years of general cardiology fellowship. Once we've determined that we do think this is a heart attack, we engage an interventional cardiologist who has completed all that, and then at least another year of interventional training. And then oftentimes, if they are ending up in the ICU, if it is a big heart attack, we have to get our heart failure team involved, which is another specialized cardiologist who's completed heart failure training. So it's a huge group effort, and it's not just the faculty and the fellows, but we also have specialized nurse practitioners and physician assistants who have spent years in these fields becoming experts at what they do.
And the training that goes in there obviously is just this massive. I every day I look at, like you just described to me, I was like, oh my goodness, because as I said, you're a fellow on that, and I was going to have some to understand so some folks don't understand what a fellow is on that, because you're a doctor, but you're working in an area as a fellow to get a certain specialty, correct?
Yes.
Along the way.
Correct.
And so that means it's constantly, this is not classroom training so much as it is you're meeting with patients and doing along those lines. How large is the cardiology team, if you want to call it that, at UTMB Health?
Oh, it's quite large, especially since we cover 4 campuses in total. Clear Lake, obviously, and then Galveston, but also League City and Angleton. We have a fellowship program here. It has over 30 trainees. Plus, we also train heart failure fellows and interventional fellows. So this puts us on par with any of the other big programs in the country, and especially as big, if not bigger, than many of our programs neighboring us in the Houston area, such as Methodist and UT Houston. We are a transplant program as well. We do heart transplants on the island, and so we have a large team of CT surgeons. They have their own fellows. So those are the actual heart surgeons that come in. We have vascular surgeons who help us. And then amongst cardiologists, we offer 4 different subspecialties here. Well, no, now 6. So
right.
We have
cardiac
imagers, general cardiologists, cardiac OB, heart failure, which we've discussed, and interventional that we've discussed. Within interventional, we also offer structural heart disease management. And then, of course, we have our electrophysiologists who are our rhythm specialists. So very comprehensive care that we're offering here, and both at Galveston and Clear Lake. And then League City and Angleton, we have some of these specialties. And of course, we always transfer to either our 2 bigger centers, either Clear Lake or Galveston, should we need those additional services. So we got our picture up of our team.
Yeah, now I got it. Yeah, now we got it to work here. This is the team right after that reaccreditation here. What was that day like, though, for everybody? I mean, when the work, I mean, how do you find out? Is it like an email? Does somebody show up like Prize Patrol? I mean, how does this work actually?
Yeah, so our reaccreditation process, it's a very long process. We actually have multiple meetings with the American College of Cardiology, ACC is what we call them. And we meet with them monthly. And what we do is we're kind of going through our guidelines as we meet with them. So we're telling them, okay, this is one of the measures that we've met. This is how we've shown how we've met it. And then we kind of go to the next one. On the last day when they come in and they actually do a survey, and this was really, TJ, you had mentioned the difference between COVID, when we got our accreditation in COVID and when we got it now. During COVID, they didn't come to the facility. Everything was via telemonitoring, right? And so we did our survey via Zoom and all those other things. And so this one was really special for us because they actually came in and they were able to not just see what we do, but they go and talk to our patients. They go and talk to our staff. They go and talk to our physicians. And really those conversations are really talking about what is chest pain accreditation to you and what does it bring to the facility. And really, it's a really nice kind of step gap from just putting something on paper to really having them come in and have those conversations with our staff and with our providers, and ultimately, really the most important people, our patients. And so really what we really like to do is have them come in, and then usually by the end of it, unless there's some glaringly obvious concern, they will let us know by the end of the day if we've received our accreditation or not. And, it was such a proud moment for us because, COVID, it really did tilt all of us in healthcare, right? And it did really help us say, you know what, even though we went through this huge pandemic, we never dropped our level of care for cardiac care at Clear Lake. And we were really, really proud of that moment. So it was a huge celebration. We were all standing and cheering. And it really was, as you see all the pictures, was such a group effort.
Yeah, with that, such a big group effort, there had to be 2 photos.
Yes.
Of
and this is still a small portion of all those involved.
That's right. It's not everybody.
We don't even include all of our cardiologists in there. We would need much more
people
pictures.
available at the time someone took a photo of that, and that's great. And one of the things I noticed too, and this is and I see an EMS provider there in this photo here. That's also a key to this is obviously while they are not part of the UT system officially, really that great paramedic care that we have in this region, whether it's League City, Clemcy, all the Galveston Ambulance Authority, of coming in and doing it. That's a key thing too, because that's that information that comes into that emergency room when someone's suffering some type of chest pain, and they're the first ones that put those monitors on them and know what's going on. That's that key part of the information, so it gets to the team, right, Dr. Davis?
Absolutely. We are very dependent on the EMS to be able to recognize what is a heart attack or what is concerning for a heart attack. And depending on what they see, they have the ability to call ahead and do a chest pain activation. That way, everybody knows that there's a high-risk patient coming in that we need to be seeing as soon as they hit the door. We're depending on them to get that initial EKG and look for the more concerning changes related to heart attack, but also start to treat the patient, treat their pain, but also give them the blood thinners that they need and give them the aspirin that they need to try to reduce the damage being done to their heart.
And forgive me, as I said, I'm at our home studio, so you're hearing my lawn guys just showing up here. Their timing just great here. When we come back, though, we're going to talk about, as we talk about cardiac care, is what some helpful tips for you as a patient or a potential patient, what you should be doing to watch out for signs, and what you can do without necessarily going all out and always, seeing a cardiologist, on your small steps that you can do. And we'll do that right after these words from UTMB
There's
Health.
nothing more important than quality health care for you and your family. That's why UTMB Health is in the communities where you live, providing easy access to innovative care. At UTMB, we know our patients need personalized care to lead healthy and fulfilling lives, providing everything from primary care and specialty care to urgent care and emergency medicine. UTMB knows healthcare. UTMB knows you. To find a UTMB doctor near you, visit utmbhealth.com. UTMB Health knows that when you need advanced surgical care, you want a specialist who's an expert in their field. Our surgeons provide innovative and advanced treatment options for adults and children, for neurosurgery, GI, heart surgery, ENT, urology, and more. UTMB knows surgical care. UTMB knows you. To find a UTMB Health specialist near you, visit utmbhealth.com.
And forgive me for the background noise, folks. Again, this is TJ Hall's I-45 Now, and welcome out to UTMB Health Insights as we're taking a look, and congratulations to the crew at UTMB Health Clear Lake for getting the reaccreditation. And this one, I guess we can call it the in-person accreditation part of it. So as you had said, Mary, when we were talking before we came on the air, was this one felt like the thing, the real deal. As you had described, you go from having the first accreditation to paper, to now the folks are experts on this, actually seeing what's being done, what's in there. That gives them a better perspective of that, because seeing is believing in this case.
Absolutely. And, I'm a big believer that paper is paper, right? You can write a number on a piece of paper, but seeing it in live action is always so eye-opening. And really what the surveyor said at the end of our accreditation, they were so delighted to see the level of engagement from not just, our staff that are really involved in it, but even with our, our physician providers and our ER doctors and our ICU doctors. Like, everybody knows that they're here to really care for the patient and make sure the patient's as healthy as possible when they leave our facility.
So obviously dealing with cardiac, folks, as we talked about earlier, the symptoms can be one thing but it's actually something else. It is a process of elimination. Sometimes there's not that, clear indicator a lot of times of what's going on. But what is it just in general that folks can do to help them keep themselves heart healthy?
Mm-hmm. So there's a lot of different resources out there. I highly recommend one that the American Heart Association puts out. It's what's known as Essential 8 is what they refer to. And basically, it's talking about getting good sleep, don't smoke, control your blood pressure, your cholesterol, have a good diet. Either don't develop diabetes, or if you have developed diabetes, control your diabetes, exercise well, and then maintain a healthy weight. They actually have a way for you to put in all your own particular risk factors, and it will calculate how well you're doing on this essential 8 scale and how many of these metrics you're meeting. Don't feel bad if you're not meeting many of the metrics, because most Americans are not. Um, about 10% of Americans have uncontrolled diabetes. 50% have uncontrolled blood pressure. 50% are not getting the recommended 7 hours of sleep. Only about 5% of Americans are meeting their exercise goal. So, the American Heart Association recommends 75 minutes of vigorous exercise per week, or at least 30 minutes 5 times a week. And so only 5% of us are doing that.
And in fact, I have the American Heart Association, that Life Essentials
Yes.
8 that you talked about, and you can actually go up and sign up for health and well-being tips on those 8 issues along the way. And I think the most important thing is don't get discouraged if you're not hitting all the metrics. Right?
Absolutely. Because, if you were hitting all the metrics, you would be a very, very outstanding citizen. Like, most people are not hitting the metrics, and they need help. And so there's online stuff like this, like American Heart Association. But of course, there's us at UTMB Cardiology. We're more than happy to see you in the clinic and go over your risk factors and help to reduce them, because the easiest way to improve heart disease is to prevent it from happening. And that means addressing these kind of things. Heart disease has been the number 1 cause of death in America for 100 years. And that's despite all the incredible advancements that have come from treating heart attacks. So it really goes back to these measures, these risk factors: diabetes, high blood pressure, high stress, poor sleep, smoking, that we need to continue to focus on and address.
And also to talk about is, as a matter of fact, we see it on the screen there, Dr. Davis, is women's heart, because we talked a little bit about that, the difference between women and how it manifests itself. And we just had an incident here, recently, a good friend of mine, a lady who, showed no signs of having of cardio problems, and not been diagnosed with anything, but and then had a heart attack. And the one thing I kept hearing her family say is that, we just didn't know anything. We didn't know what was coming. And it wasn't until afterwards that then they started hearing from the doctor, and like, oh wait, yeah, she was having that problem, or wasn't having that. And there's always that kind of, oh, well, it's not that big of a deal, I'll dismiss it. That's always going to be a factor with any patient, no matter what. But how important is it for women to really pay attention to the signs that are there?
Oh, incredibly important. And, it breaks my heart every time I hear these kind of stories, but unfortunately, they are very common. For many, many years, heart disease was thought of as man's disease. There's actual old pamphlets put out by our governing societies from like the 1960s. And they're saying, when it talks about women and heart disease, it's how do you prevent your man from having a heart attack? Because it was legitimately thought that women didn't have heart attacks. It wasn't until the 1990s that it was really recognized how big of an issue it was. And we have the legendary Dr. Nancy Wegener to thank for that. And she really revolutionized cardiovascular care for women and pushed the NIH to invest in looking at women's cardiovascular health specifically. And then in 1990, so at this point, we've been studying heart disease for almost 40 years, was the first time that we had guideline recommendations specifically for the care of women. But still, women are vastly undertreated. It is the number 1 cause of death in women, and it's usually under-recognized. And not just the heart attack, but all those other things we talked about, all those risk factors are undertreated in women compared to men. Why this is? A lot of it is, like lack of education, not just amongst healthcare providers, but amongst patients as well, just not understanding, as you said. Women have very unique risk factors that are part of just being a woman. Any kind of pregnancy complications, such as preterm labor, eclampsia, gestational diabetes, all of that increases your risk for heart disease down the line. And then there are things associated with menopause. Now, to be clear, menopause does not cause heart disease. But when we lose that protection of estrogen going through menopause, basically we catch up to men. So blood pressure goes up after menopause. Cholesterol levels go up after menopause. And this change is often not recognized by patients or providers. And so it's important to talk to your primary care providers, especially as you go through this phase of life, and recognize that your risk factors are changing. And so maybe it's not enough to check your blood pressure once a year when you go see your doctor. Maybe you do need to be checking it more frequently because your body is going through a rapid change.
How often should we hear a lot about, for example, particularly for women, of do self-examinations for your breast for breast cancer, get a regular mammogram and the like. When it comes to cardiology, what should we be telling men and women about how often they should see their cardiologist or someone in cardiology?
So I would say at minimum, people should be seeing a doctor at least once a year, a primary care doctor specifically. And if you have these risk factors, things like high cholesterol, high blood pressure, you should definitely establish with a cardiologist. We get these kind of referrals all the time in the clinic where people just want to know, like, what are their heart risk based on their risk factors. And those are our favorite visits, right? Because as I said, the key to really impacting heart disease in America is going to be prevention. From there, you should talk to your cardiologist to decide what's best for you. And our folks who do have a lot of risk factors, we usually have them follow up, 2 to 3 times a year. But if you have high blood pressure and it's controlled on one pill and it's stable and has been stable for a long time, that's something that sometimes we're like, okay, only once a year do you need to come and see me. So I would say at minimum once a year if you have risk factors, and then you may need more depending on what your risk factors are and how well controlled they are.
Mary, your crew's on the front line more and more now, and Dr. Davis, you can also answer on this, but what is the balance between men and women now coming in and dealing with cardiac problems?
Yeah. And, Dr. Davis had mentioned, when they come in and they say they have chest pain, that's mostly our men. They're the ones coming in stating they have chest pain. Most of our women, when they're coming in, they're saying they have stomach pain or abdominal pain, as we call it. And so you can definitely tell you're getting the same amount of patients really with the concerns, but really what you're seeing is that differentiation. And I think, to Dr. Davis's point, that really until the 1990s, nobody even knew that women were having these situations and these, cardiac issues because they were being shown in such a different way than just chest pain. So definitely when you're seeing them come into the ER, you hear a lot of chest pain from a man, and you hear a lot of my stomach hurts from a woman, or I'm nauseated from a woman. Like you hear those kind of symptoms much more from a woman than a man.
Is there been some study that shows why studies that shows why that these symptoms reveal themselves in different ways based on gender?
So we're not totally sure why, but we do know that women's metabolism and the way we develop cardiovascular disease is unique from men. There are some things that we share in common, like high blood pressure, high cholesterol. Obviously, those things all predispose us to heart disease just like men. But because of how our bodies go through our life cycle and our life changes, and we go through pregnancy and we go through menopause, the way the disease develops and the timeframes in which it develops are often different. Women on average present about 10 years later in age after men. But when we do present, we're actually more likely to die from heart disease than men. And it all goes back to some of the way our bodies respond to things like inflammatory processes and how the actual disease of the vessels lays down.
Thank you both for being on. Dr. Elizabeth Davis, a cardiac fellow and cardiology fellow at UTMB Health, and then Mary Phillip, the Associate Chief Nursing Officer for UTMB Health Clear Lake, and the League City campuses. Thank y'all for the information. Sorry about our start out there, but some valuable information. If you want to find out more, go to UTMB Health and click on cardiology, and you will find out more there along the way. Thank you all both for coming on. We do appreciate it. And thanks to David Bethea. And again, folks, this show will replay here almost immediately after the live stream stops here. If you have any questions, though, you can send them straight into UTMB Health. They have a great interactive there on that. But as you heard Dr. Davis said, get in to see your doctor at least once a year. And if you have any stomach or chest pains, make sure you go to go into UTMB Health Clear Lake. They got the accreditation. We got to make sure we're pumping that. We should point out too that Clear Lake's not alone with their accreditation, right? We should point out that, but that's the one we're bragging about.
Yes.
I don't want anyone to think, we can only go to Clear Lake, which, as you told me, Mary, before we came on the air, the secret's out at UTMB Health Clear Lake, is it not?
Yes, it absolutely is.
Yeah, that's it's a busy medical center over there. That and its little cohort building that's right next door to it. Out there, word of advice: if you do go to UTMB Clear Lake, just go ahead and park in the parking garage, because service parking, just give up right now. It's already full.
We also have valet, TJ. We have valet. Use the valet.
That's true. I use the valet all the time. I like those guys.
Yes,
the two guys.
Use the valet service there.
Yeah, the valet service. I like the one guy has this e-bike that I just love. I want to get over there, but yeah, if you're gonna go there, either use the valet service or the garage, because you ain't gonna find service parking. I'm just tell you right now, no matter what time, midnight gonna be full, 4 a.m. full, 10 a.m. full. They're just maybe not that bad, but thank y'all both for coming on. We appreciate your time here today. Stay with us. We're gonna have, actually, it turns out to be 2 shows in the month of March. That we'll be having, because we did had to delay this one for a couple of weeks. Thanks for you both for being patient with me on that. I'm TJ Alls. This has been UTMB Health Insights.